my research focus, my research interest is in heart disease in patients with liver disease, and how the liver affects the heart and how the heart affects the liver, which is a very niche area, but also a very important area. And that's because most people don't know, but the leading cause of death after a liver transplant is actually heart disease. So 1 in 3 liver transplant recipients will have a complication related to heart disease within a year after transplant. So it's a big problem. You get somebody through this life-saving operation, you don't want them to have a heart attack or have heart failure or a stroke, and that end up being, somebody's cause of death, or keep them in the hospital for long periods of time. The other thing is that fatty liver disease that I talked about before. The leading cause of death in people who have non-alcoholic fatty liver disease is heart disease. The second leading cause of death in people with fatty liver disease is cancer. And the third leading cause of death in people with fatty liver disease is actually liver disease. So that means that my passion and my role as a researcher really mirrors what I see in clinical practice, and that my goal is to use large population-based approaches and large data approaches to look at the epidemiology of these diseases, identify what the major causes of death and complications are, and then to take that knowledge and then translate it into clinical practice. So we kind of call it translational epidemiology. So I spent the early part of my research career developing my epidemiology skills. So I think a lot of us in the lay population are more familiar looks like now because of COVID, because of all the statistics that are getting thrown out there all the time about what's the case rate, what's the percentage of cases that are positive, and needing to think about how we handle data and how do we think about data and how do we think about population health and population level data. So that was a lot of what I did, and identified that these were really important problems. But then, of course, as I'm seeing patients in clinical practice, I recognize that I actually want to try to do something about it, not just say there's a problem. I want to actually try to intervene. And so that's where I started getting involved in health outcomes research and health services research, which really focuses on patient level and systems level interventions to try to improve disease outcomes or improve processes of care. And so my focus over the last couple of years of my research and my research training has been to specifically develop a quality improvement toolkit to help to reduce the rate of cardiovascular complications and death after liver transplant. And so we've done this in a couple of cool ways. We have done very traditional type clinical research science, data science, like again, using large electronic health record databases to answer important questions about like what percentage of patients who have high blood pressure are getting appropriate blood pressure medicines, are they getting prescribed, are they getting referred to the right doctors? And then once we figured that out, actually surveying and doing some other work where we surveyed healthcare professionals across the country to try to figure out what they thought the appropriate intervention should be for different risk factors for heart disease. And then we did a bunch of qualitative research like you're doing right now, where we did interviews and focus groups among different healthcare providers. We did patient focus groups. We did caregiver focus groups of people who cared for liver transplant recipients, and tried to figure out like what are the biggest barriers for you in accessing heart disease care after transplant. Do you know that heart disease is a major problem? What kind of education things would you like to see? How can we better help you understand this message? What can we do better as the healthcare system or as physicians? And got some really cool responses. And now we're developing and working with a graphic design team to develop education toolkits and electronic health record alerts and provider handoffs and patient report cards and all these cool things that'll be in this toolkit that we then hope to implement across different health systems to try to improve care. So that's an example of what translational epidemiology looks like. Identifying a problem when I was a fellow many years ago, actually in 2012 is when I started this project, and now here it is, 8 years later, and we're working on the translational impact of that and trying to improve care. So that's the type of research that I do, and there's other examples of different areas of that sphere, but that's one. My amount of time that I spend doing clinical research is a lot. I currently spend about 80% of my time doing research, maybe even a little bit more sometimes. And that's because one of the ways that you can formally pursue a career in research in academic medicine is actually to have funding from the National Institutes of Health, or the NIH, to fund your research program. And so I had funding when I was a fellow. I was in a training grant from the NIH, something called an F32, that I was awarded so I had a mentor team that was mentoring me on that award. And then when I came on faculty at Northwestern, my institution had been awarded grants from the NIH to find trainees at their institute, or find young faculty members at their institution who had promising careers in research who they could support for 2 years of time, where the NIH gave money to Northwestern to pay a portion of my salary to protect my time. So I had that grant for 2 years, and then I wrote my own individual career development grant called the K Award, which I'm on now, and that's another 4-year grant that I'm in the 4th year of that grant, where I have been getting 75% of my time protected by the NIH to do research and to develop my skill set in research. So I've taken lots of extra classes. I got my master's degree in clinical investigation after I finished medical school. I did it during residency and finished it during my chief year. And then I've taken even more classes and education opportunities to develop my skill set. So that's what my life looks like as a NIH-funded clinical investigator at a public university right now. So sort of a very traditional academic research pathway. And I hope that long term that my career will probably look like about 60 to 70% of my time will be spent doing research like I do now. And then the other 30% or so is spent really in clinical care. And then teaching happens all the time.